We are here today with Dr. Lizzie. She is a sleep medicine physician and a faculty member at Harvard's Medical School Division of Sleep and Circadian Disorders. Now, I got to tell you, this was a fabulous conversation. And I wasn't sure going in, like, okay, so how do I talk about sleep? Like, where do we go here? And she and I had a 90, almost 90-minute conversation about sleep. And you are going to want to hear this episode. Okay, so I look at this. This is my notes. I'm a copious note taker, and I love writing down all the things that my featured guests say because it's so important to um they just give me all these juicy little takeaways. Okay, so um we started the conversation, and what she began to say is there is a difference between fatigue and sleepy. And I had my definition of sleepy reversed. But here's what she says. So fatigue is when you feel emotionally or mentally burnt out, that you have brain fog, that you're just genuinely exhausted. Sleepy is where you are sitting at your computer and you just close your eyes and you feel like you could just completely fall asleep. So we talked about that. We talked about how that works and why that contributes to, feeling exhausted all day. She validated for those of us who are, maybe you are pregnant, maybe you have small children, maybe you are a teenager, maybe you are a person who works and your work is stressful and you come home and you just don't know how to unwind, and then you get into bed and you lay there and you think about your work all night until you drift off to sleep. Maybe you are in perimenopause, you are in menopause or andropause, or maybe you're an elderly person. So basically, everybody. She talks about what works. She talks about the validation of being a hardworking person, and that we deserve, if you find yourself in those categories, we deserve a good night's sleep. She talks about interrogating your daily routine, which means, how much hydration am I getting? Am I getting myself ready for bed 2 hours before I go to sleep? And I said to her, pardon? I get myself ready for bed, but I don't create the space 2 hours before bed to go to sleep and let my body know that that's what we're doing. And so she talks all about that. She talks about sleep apnea, cognitive behavior therapy. That's a gold standard to restore the relationship with sleep. She talks about CPAP machines. She talks about um, melatonin. You got to listen to it. If you're a melatonin taker, come on in. This is a good conversation for you to listen to. Talk about sleeping devices. And then in each of those categories I listed, pregnancy, moms, dads with little kids, blah, blah, blah. She talked and spoke directly to each of those spaces. And in particular, I'd like to mention the teenagers. Okay, so if you have a teenager or you are a teenager, listen, this conversation is really good. Dr. Lizzie is adorable. I just love her so much. Anyway, I would like to offer you this conversation with this amazing Dr. Lizzie. She is a sleep medicine physician, a faculty member at Harvard Medical School Division of Sleep and Circadian Disorders. She is on with me today. All of that said, you get to hear this next episode. And man, is it fabulous. Join her and I as we talk about sleep. I've really been looking forward to this interview with you.
I'm so excited.
I have, I don't know if I have so many questions.
Mm,
I mean, I do, but it's more about trying to figure out how to solve this Rubik's Cube of sleep problems. And you seem to be the right person to help with that.
I hope so.
Well, so what have you been working on? Talk to us about kind of what you do.
That's a great question because I think when people hear sleep medicine, it's a little bit of an unusual medical specialty and can seem kind of like a black box, especially when you get that referral from your primary care doctor. So on a day-to-day basis, my job is focused on helping people improve their sleep at night so they can feel their best during the day.
Okay, well, good luck, right? That's the show. Okay. Thanks, Lizzie. We appreciate it.
Oh, no problem. Yeah, that'll be $200.
Exactly, exactly. Um, right. You say this is kind of it's not a black box, it's a black hole in my view.
Mhm,
It's
mhm.
like, where do you go with sleep problems? And lots of people don't know they even have sleep problems.
Yes, yeah.
So, can we start? Where do we start?
I uh, so I think taking a moment to assess how you feel throughout the day in regards to energy level. When are you feeling your best? When are you feeling your most alert and awake? And when are you feeling a drop off in energy? When are you feeling like if you are sitting down, engaged in a passive activity like watching a movie or driving, do you feel yourself nodding off? Um, I think that's a really good inventory to take because if you find that, especially compared to other people around you, that your energy levels and your level of alertness and your sleepiness level is different than the general public's, that's an issue. And I think it's very easy to kind of brush off fatigue as, oh, I'm overworked. Oh, I have too much on my plate. But in a lot of cases, it can be indicative of a disease process or at least something that someone like me can help with and help you, distinguish what's normal from what's not normal.
Ooh. Okay, so what if you're 50 menopausal and there are 2 billion of us in the world who who have sleep problems because our hormones are changing, or we have a bed partner who snores, or like, how do you sift what you just said there? Because like fatigue for me, if my partner has a good sleep, I'm good.
Mm-hmm.
But if he has a poor sleep, he's restless, maybe he's snoring, I'm not good. Then
Mm-hmm.
it comes to me where, okay, so if I take progesterone, I'm good. If I have too much sugar, I don't sleep. So how do everyday levels affect what you're talking about? Because it's kind of the gamut, don't you think?
Yeah, and I think your question, or how I would address your question in my clinic would be, well, I think you're addressing you have two problems. One is that your partner may have an issue with the snoring, with the restlessness. That can be any number of things, including sleep apnea. It can be restless legs, or it's uh similar condition called periodic limb movement disorder. So, getting your bed partner assessed and treated for sleep disorders is a big contributor to helping you get your best night of sleep. So, I think that's step one. Step two is also kind of taking inventory of what is fatigue and then what is sleepiness. So, fatigue is going to be this feeling of emotional, physical, mental burnout. I'm feeling run down. I'm feeling overwhelmed. I'm feeling like I have brain fog or cognitive um, issues. That is fatigue. And then we have sleepiness, where I'm sitting, I'm at work, I'm at my computer, I'm in a meeting, and if I were to, I feel my eyelids getting heavy. If I close my eyes, tip my head back, I would actually fall asleep. And kind of seeing, are you having one of those symptoms, both, or more one compared to the other? And then that would, from there, we would move forward with our medical workup. Do you need a sleep study? Do we need to do iron studies? Do you need more of a toxic metabolic infectious workup to get to the bottom of what exactly is driving these symptoms that are really affecting your quality of life?
Okay. So excuse me. You said something iron. We would look at iron,
Hmm.
toxic metabolic inflammation workup. Okay, so I get the distinction between fatigue now and sleepiness. I would have reversed it the other way. I would have said fatigue was where I could just close my eyes and fall asleep at my desk versus and sleepiness was kind of the brain fog, but it's just a different way of explaining it. But you've helped me separate that now because fatigue, as you say it, feels more like what you're saying, the absolute mental exhaustion, brain fog, that kind of thing. So now I get it.
Mhm.
Because I always think to myself, oh, I'm sleepy. And I use that word, I'm sleepy, but
Yeah.
that's not what it is. You're saying no, that's not that's like fatigue. Okay.
And a lot of the times they run together, and they're synergistic. So if you're sleep deprived, you can feel sleepy. That's driving, when you're running on empty, that's driving fatigue. But a lot of times teasing them out, and having the language to help describe what's bothering you the most can be really powerful as you go into your doctor's office.
So before I move to the iron and the toxic metabolic inflammation, can you give us words? Because I don't want to lose that. I don't want to
Yeah.
lose this incredible takeaway. What words would we be saying to our primary care if we needed help with this?
Yes, I think this is so important because there can be such a disconnect between what the patient is saying and what I'm hearing. So for me, key words that I want to hear that tip me off to somebody who is sleepy are people who are having trouble staying awake during passive activities. So they're sitting at their work desk. Eyelids are heavy. They're nodding off, sometimes while driving, sometimes while sitting at red lights, and this is an altered level of consciousness versus fatigue, which is something, a symptom that can feel like I'm run down, I'm burnt out, I'm exhausted. But if I were to sit at a work meeting, maybe I'm struggling with paying attention, but I'm not actually falling into sleep while I'm at my desk.
Oh my goodness. Okay, that's so helpful. That's so helpful. Okay, so then we go to our doctors and we say,
Mm.
what do we say? I'm struggling with.
I'm struggling with staying awake during the day. I find that I need to take more naps than usual. Coming around like the 2 p.m. post lunch period, I find that I need to put my head down and fall asleep for a little bit in order to just get through the rest of the afternoon. If I'm sleepy, maybe I'm getting home from work and all I'm capable of doing is watching TV. It's hard for me to get to the gym just because that physical level of alertness is not there. Um, Fatigue can feel similar, but it's more of a sensation of just feeling like really burnt out. I'm tired, but if I were to lie down, put my head down on a pillow, I wouldn't fall asleep, but I would feel like I maybe couldn't get out of bed.
Oh, I'm all of that.
And a lot of people struggle with both.
Help!
And this, and this is the patient that if you struggle with both, we can address it in a stepwise process. This isn't an impossible thing. You're never wrong for having the symptoms or the lived experience that you have.
Yeah.
It just means that maybe it's going to take a little bit of time for us to unravel, what are all of the drivers behind these things that are causing you to have a impaired quality of life.
Well, this is interesting because I would use the word impaired quality of life to describe. Um, Now, I think if as I'm reflecting as you're speaking, I'm
Mhm.
thinking for myself. So those who are listening, just start thinking for yourself and then write in and ask questions because that's how you're going to get the answers from Dr. Lizzie. But so for me, I'm thinking out loud here. So I know I have hormone. I'm at that age, right? But
Mhm.
but here's the thing. I'm a mother of four children.
Oh my gosh.
I know. Beautiful kids. But good Lord, I was exhausted. I mean, so how do you determine like you have sleep deprivation, and we know this when we have kids. But then as you get older and the kids get older and you're not waking up all the time because of them as infants or newborns or toddlers, but now you're waking up because you now have other problems. You've got stress in your life with your work or there's all these different things. How do you help someone navigate through general burnout of life? Because if you haven't kept up, I mean, I just started keeping up with myself from when I started having kids at 23 to now I'm 49 and I'm in menopause and I'm thinking to myself, okay, so I'm not having children anymore. That's true for me. My body says we're not doing that anymore. Well, now there's a whole new world happening and I can't decide what works best for me at this point.
I think one thing to the first, if somebody came into my clinic with this issue, the first thing I would do would be to validate all of the hard work that you have done to raise four kids, to say you have been through so much, your body has gotten you through so much. How now, how, in this new life that you have and that you've earned for yourself,
Mm,
how do we get you back to a point where you are comfortable? Because that's what you deserve. And that is how we are going to promote this quality of life for you going forward. And I think the first step is to interrogate, what are you doing on a daily basis? Are you hydrating? Because, you've put your needs aside for so long. And how do we get you back to a place where now your needs are at the front and center of what you're doing on a day-to-day basis? So just the very basic things like hydration, diet, um, putting aside 7 to 9 hours of sleep a night, having a robust wind down process starting 2 hours before you're going to put your head down on that pillow, making sure that some of these pieces that may have been put aside during the intense parenting years, like social life, um, even things that come down to appropriate medical screenings, making sure that you're up to date with your primary care doctor, that the basic labs look good, thyroid function looks good, and just getting you to a point where now your health is at the center, it's being prioritized, and those basic pieces are in place. And after that, how do your energy levels respond to that? Then, okay, better, but not perfect. Still, you're feeling maybe a little bit better, headaches are less, energy levels a little bit improved, but now we're still seeing the disrupted sleep at night. Then we discuss, okay, well, we could consider cognitive behavioral therapy for insomnia, which is the first line treatment and gold standard of treatment for insomnia. This is a therapy that is provided by fantastic practitioners of cognitive behavioral therapy, and they'll help you restore your relationship with sleep, which has been, again, disrupted by so much of life. So that can be a really productive first step. And then we consider if this syndrome is robust enough, do we need to add a sleep medication and see, does stabilizing the sleep at night get you kind of over the hump until you can regulate on your own a kind of normal night of sleep?
Oh, that was so full of information.
Yeah.
Thank you for that.
Yes. Sorry. I think about this all day, so I hope it wasn't
I love
overwhelming.
that you think about this all day. That's so important to me.
Uh,
Okay, so what you said there was first you would validate the hard work and the hard effort and of
yes.
what myself, my partner Dave, what we did as parents in those early years. And so I thank you for that because that is for those of us who are, coming out of those parenting years, we need to hear that because we don't
Yeah.
maybe know that. And what you said is then you begin to interrogate your daily activity, which I
Mhm.
think is really important because hydration, um, the basics, the labs, all those different things. But the things that I wanted to ask you about are 2 hours before you go to
Mhm.
sleep. Okay, so this means phones in a bed, TV on, and then I'm so tired I turn it off. This is what you're going to tell me that I'm not going to be doing, right?
I would never tell you to stop doing something that is really, really important to you. If it is, a great, if you love watching TV in bed, if this is your thing, it's your husband's thing, it's something that you just don't want to give up, I would never say, pull out the plug, throw it out, we're done with the TV in bed. Because this is at the end of the day all about improving your quality of life. And I'm not in the business of being, the TikTok police or the TV police. What I think the important thing to understand when we talk about wind down before bed is that our body is cued by stimuli in our environment. It's a reciprocal relationship. So we have to tell our body that it is time for bed so our body can be prepared for bed and in turn release the hormonal signals that promote sleep onset. So if you have all of the lights in the house on, loud noise, are watching scary movies, 15 minutes before you want to try to go to sleep, that is a very stimulating pre-bed uh, pre-bed kind of activity to engage in. It's going to get your cortisol levels up. It's going to suppress melatonin release. And it's going to be very, very hard for your body to understand that now, after just going through something very stimulating or stressful, that now it's time for sleep. That's a very mixed signal to send your brain and your body. So when we talk about, reducing the doom scrolling, reducing the TV before bed, this is really to make sure that people understand that our brain is going to respond to what we're telling it that it's time for. And if we're not saying it's bedtime, then that signal is not going to be produced endogenously.
Wow. Yeah, it all makes sense.
Yeah,
It just
it's a bummer, but it makes sense, right? Yeah,
it totally makes sense to
yeah,
me.
yeah,
I mean, I I get ready for bed,
yeah,
but that's where I stop. Like I put my jammies on, I do my face, I do my things, I do all my stuff, but I don't mentally get ready for bed.
yeah.
Wow. Hmm. Okay, that's something that's really important.
Mhm.
Okay, so I got to go all the way back to because you were talking about sleepiness, fatigue, what works, the validation, cognitive behavior therapy, you talked about wind down. Now I need to move us to this where you said looking at labs and you're going to want to check
Mm,
iron and you're going
yes.
to check toxic metabolic inflammation. What?
Yeah, so when I say kind of toxic metabolic and then an infectious workup, this is if somebody's ha that's okay. But infections cause inflammation. I totally know what you meant. The when we think about sleep dysfunction, or really and fatigue, we want to make sure that there's no reversible medical cause of fatigue. Um, Fatigue usually has a lot of different driving factors, and sometimes we get very lucky and see a very obvious cause in the labs, like thyroid levels are a huge driver of sleep dysfunction, hypo and hyperthyroid, sleep dysfunction, and fatigue. So we want to make sure those are checked. Vitamin D is another big one, especially I live in Boston. Want to make sure vitamin D levels are appropriate. And, if I see a low vitamin D level, that can also be a surrogate measure of, hey, what are you doing during the day? Are you getting out in the sunlight? Or are you just sitting in a dark room? And is that making your sleep schedule erratic? So I really like checking vitamin D. I think that's very helpful. Iron levels. Iron is a huge issue. It's a very common nutritional deficiency. It can drive restless sleep. It's also really important for the neurosynthesis and packaging of a lot of different um, neurotransmitters like serotonin and dopamine. So, um, correcting iron levels and making sure that those are appropriate is something that I spend a lot of time doing and making sure my patients have good iron.
So do you find how often do you do these tests? Because is this is just a standard? If you can, you're talking about the first step. Is this the first step, really? The iron in testing for toxins?
And I should be more specific. I don't really test for like toxins in the way that maybe the wellness industry has used the word toxin. By toxic metabolic, I mean lab levels that are abnormal that could be correctable and that don't have to do with infectious disease.
Okay.
So I would consider it a first step for somebody who has fatigue and it's not abundantly clear to me that they have sleep apnea. So if somebody is complaining or talking about fatigue in a way that they're maybe having other digestive problems, they're having hair thinning, maybe their appetite is either low or high. Um, we're thinking, hey, we can do a sleep study, but let's also get some lab work and see what's going on, especially if they're complaining of really restless sleep as well, or sleep fragmentation can be an important thing to make sure that nothing else is there that I want to investigate.
What is, can you define sleep apnea for us?
Yeah. So so sleep apnea. Apnea is Greek for cessation of breath. Um, there are two types of sleep apnea. There's obstructive sleep apnea. This is intermittent closure of the upper airway that occurs while you're asleep. This is the far more common type of sleep apnea. The main contributors to sleep apnea are abnormal upper airway anatomy, either something you are born with or your tonsils are a little bit too big. This part of the body is a very anatomically congested area. So it's a game
Right
of,
here.
yep, right through here.
Okay.
It's very anatomically congested. So we have a lot of lymphatic tissue, a lot of muscles. We have our tongue, our palate. And so if any of those parts of your body are just a little bit too big, it can result in intermittent, partial or complete closures of the upper airway throughout the night. That's problematic because it disrupts sleep architecture, results in the release of cortisol. During a time of the day that's supposed to be very restful, restorative, and pretty much give our organs a break from us and our wakefulness and the activities we do during wakefulness. So sleep apnea can put a lot of unnecessary strain and stress on our organs, and particularly our heart is what we're most worried about. The second type of sleep apnea, which is a lot less common, is called central sleep apnea. This occurs when what our brain is essentially dropping the signals to trigger a breath while we're asleep. We see this on the border of sleep-wake states. So if somebody is moving from a state of sleepfulness to a state of wakefulness, sometimes the brain will drop breaths, resulting in something called post-central arousal events, or post-arousal central events. And then,
So when the brain drops the breath, what is that? Is it mean you kind of go like you gasp? Is that what we're talking about?
so this is a very specific physiologic or pathophysiologic process that occurs um, when you wake up from sleep. I think the gasping and choking that you're referring to
Yeah.
is associated with obstructive sleep apnea, and that's when we get that kind of choking like sensation
Oh,
from the closure of the upper airway. Central apnea is a lot more rare and maybe not worth spending a whole lot of time on.
okay. Okay, but you said the brain drops the breath. What does that mean?
It means that the signal to draw a breath in, or to for the mechanics that allow us to breathe, that signal does not get sent. And that is occurring a couple of times or frequently throughout the night, depending on the severity of central sleep apnea. Usually this somebody has is either on a specific type of medication that causes this, or they have a predisposing condition like heart failure or stroke.
So with I know lots of people who are on the sleep machines and things like that.
Yes.
I, is that great?
I love CPAP machines. That is to treat sleep apnea. Again, usually obstructive sleep apnea. They provide a column of continuous positive airway pressure to the upper airway. And they push, when we think about sleep apnea, it's tissue in the back of the throat getting in the way of a breath being drawn in. And CPAPs just take ambient air, pressurize it, and move tissue out of the way. So they're very effective. They have very few side effects. They can be very difficult to get used to at first. A lot of times people with sleep apnea feel so much better after they start using their CPAP.
So yeah, I mean I've heard people say that their lives have changed. They have more
Yeah.
energy, they have more everything, right? So then just while we're still on the sleep apnea, um other devices. There's a lot of devices out there. There's like the mouth guards, and then there's like what works for people with sleep apnea of if they don't want a CPAP machine, what works? What do you recommend?
Yeah, and I'll be the first person to admit that CPAP machines are not for everyone. They're just they're hard to get used to. Some people are claustrophobic.
Yes.
I love them, and when they work, they're great. But again, they're just not going to be the answer for everyone. So the other first line treatments we consider for sleep apnea, one is a mandibular advancement device. This is an oral appliance that's a small, lightweight plastic retainer that's made by a dentist. And what it does is it moves your jaw forward while you're asleep. Your jaw is connected to your tongue. And when you move your jaw forward, it clears the airway. Um, so, um, uh, if you can't tolerate the CPAP, these are a good option. I prefer them for mild to moderate sleep apnea. Once we get into severe sleep apnea, sometimes they're not going to give us the level of therapy that we need. But again, I'd rather have you use something than nothing. So if the CPAP isn't an option, we can always look to these devices.
So how is sleep apnea and snoring connected? Like some people, what is snoring? Because we all know what snoring is, but I'm meaning more like Is it just a noise that people are making, or is there something that is obstructing the back of the throat? Like what is that?
Exactly. So it's a partial obstruction or a hypopnea. Um, it's a partial obstruction of the upper airway. And if you think about the amount of noise that it would create to draw, your body is working very hard to draw air through a partially closed airway, and it's moving that kind of that tissue around and causing vibrations, and that is contributing to the volume of noise that's being produced.
So the louder someone snores, the more the body has to work to get that air through.
I would say that's a general trend. There are going to be other contributors to volume, like depending how maybe heavy somebody is. You know, if they have a lot of kind of pressure on top of their thoracic cavity, or which is going to cause it to echo more. But yes,
Sleeping on the side or the back?
yeah. Positional position can absolutely affect sleep apnea. When we side sleeping is generally much better for people with sleep disordered breathing issues compared to back sleeping.
Okay. Yeah, yeah, I can see that, right? Because it's less pressure, less, and then the neck is back, and like, okay, so then there's people that sleep with 1,000 pillows to sort of try to make their neck do whatever it's going to do. What do you recommend for pillow positioning, and how many pillows? Like, what is that? How does that work?
Yeah, so elevating the head of the bed, you can try 45 degrees.
Sure.
Um, it's gonna be based on comfort, and what you can do is get an app to measure kind of the volume of your snoring and
Right.
then titrate. There's one called Snorex that I think is free. And you can actually, kind of arrange your pillows and then look at the app, the data that the app is giving you, and see, what's best for the snoring since you might not know since you're asleep.
Right. Well, your partner will know.
Yeah. Yeah, usually there's a lot of bed partner feedback. Yeah.
Yeah, there's a lot of bad partner feedback.
Yeah. Yeah.
No offense, anybody out there.
I know.
We're just trying to get you information. That's all we're trying to do here. No judgment, except you got to put toothpicks to keep your eyes open.
Yeah.
Okay, so can we talk about the impact? Because, if we're talking about fatigue and sleepiness, and we're talking about maybe low iron or hyper or hypothyroid or, sleep apnea, all these things. What is the mental and emotional impact of no sleep? Because, like, I remember it was maybe 6 months ago where I was in menopause and I wasn't sure. I was beginning to test. I got a hair in my mouth. Sorry. I was beginning to test which hormones were working for me. So what kind of how much estrogen did I need, how much progesterone, that kind of thing. So my doc and I were working together. Well, I I didn't quite get the diet the uh dosage right. And for 6 days, I was waking up every hour. And I was waking up. So, Lizzie, I would go to bed in complete exhaustion. I'd
Mhm.
almost, if I laid down to wait for Dave to finish brushing his teeth and all that stuff, I'd be asleep in my clothing. I was so tired. But then, so if that was 9:30, say, I would wake up exactly 1 hour from the time I fell asleep, and I would do this every hour until my alarm went off at 6 a.m.
Uh,
For 6 days, I was blind. I was so tired.
yeah.
So,
Yeah.
mental toll of that, okay, that's insomnia, right? And
Mhm.
people are living and working and they're saying I'm up almost every hour, or I'm only getting 2, 3, 4 hours of solid sleep, and then I'm restless. What is the mental and physical and emotional impact of this?
I think it cannot be overstated. And I'll tell you that so I was an intern in 2020, was on the front lines of the COVID-19 pandemic, and it was a very difficult time to be in medicine. I did my sleep medicine fellowship through Harvard Medical School, and I think it was the third day I was in my sleep medicine fellowship, and somebody came in who had truly not slept for 3 days. And she was so acutely decompensated. She was hallucinating. She was detached from reality in a way I'd never seen a patient be detached from reality before. And I think it was the scariest patient presentation that I have ever seen because, um, one, she had taken we had tried different sleep medicines, nothing was working. And two, we had to admit her to a psychiatric unit for observation because her hallucinations were getting progressively more paranoid. Um, so when we think about the implications for sleep deprivation, in the immediate problems they cause, and then the problems they cause in the long term, and the lifetime impact on health, on cognition, on quality of life. It's really bad.
It is really bad because I feel for her because,
Yeah.
3 days for her, 6 days for me. I wasn't hallucinating. I was, thank goodness. Um,
Yeah.
and I think it just hits different people in different ways, right? But for me, it was unbelievable. Like I really couldn't work.
I
I
believe it.
just couldn't. And then I was kind of beside myself, like just sort of what. And I was trying everything. Now, what I didn't do is one of the questions I wanted to ask. I did not take melatonin,
Hmm.
and I wasn't sure if it would help or hinder. So, can we talk about the role of melatonin? Just lots of people take 10 milligrams or whatever it is. What's your take on that? What do you think?
Um, Melatonin is from sleep medicine recommendations. It's not really great for sleep onset or sleep maintenance insomnia. So the what you were experiencing was what I would call acute sleep maintenance insomnia, meaning somebody who's having a trouble staying asleep. Um, Melatonin is really great for circadian rhythm disorders. And this class of disorders is people who have it's an organic brain condition, and people's melatonin is secreted in a way where they either have a much later bedtime or a much earlier bedtime compared to the general public, and it's impacting their life. Um, and melatonin can be used to help them either delay their circadian rhythm or advance their circadian rhythm to a time that's more socially acceptable so they can either get up for work or stay up late so they can have an appropriate social life. The role of melatonin in insomnia is very limited, and I think that's why people tend to take these high doses and it doesn't work, is because that's not what it's designed to do.
Hmm, this is interesting because I I mean I somebody prescribed me melatonin for the menopause portion, it liquid, like a
Mhm.
liquid drop. And I think it worked for a few days. And then my body started not wanting it. I was forgetting that I had it. I was reaching for it and then going, nah, it doesn't feel right. Maybe that's why. Now, I have a question about circadian rhythm. For those of us who are not familiar with what circadian rhythm is, would you please offer us the meaning?
Yes, our circadian rhythm is the cycle our body goes through in about a 24-hour period that dictates sleep versus wakefulness. So when are we waking up? And when are we going to bed? And when are we getting sleepy? And then when are we falling asleep? That's kind of the most basic definition of what a circadian rhythm is. Every single cell in our body is programmed to a circadian rhythm, and it dictates a lot of things that maybe go underappreciated. Like it dictates appetite, it dictates hormonal release, and then most famously dictates energy levels and how they wax and wane throughout the day.
So it circadian rhythm dictates appetite, hormonal release, and how your energy level wax and wanes throughout the day. Okay, so some people have, that I know some people that are like, I'm night owl, or
Yeah.
that kind of thing. And then there's some people that can go to bed. Like, Dave and I, honestly, we look at each other now and we just kind of give each other the look, and it's like 7:30, and off we go to head into our because after the end of the day, we just want to read and lay in bed and like have a little cup of tea, and for anybody that's in our house, they come and visit us or whatever, but we just like that space. We're not, but we would want to go to bed earlier. So there's these different levels. Is that the circadian rhythm? That's what it is.
Yeah. Yeah, exactly, exactly. So people generally, and another thing that can be a circadian rhythm issue, or not issue necessarily, but attributable to the circadian rhythm is a lot of times after lunch, people have a little bit of a dip in energy and then it kind of recovers into the afternoon. So that's kind of what I mean by wax and wane, where we're not kind of starting, maximum energy level when we first wake up and then it's a linear, decline until we go to sleep. There's some ebbs and flows throughout the day.
So like I've always, well, okay, wait. I haven't always. I gonna change that because I do have noticed a difference in my sleeping, and I'm really happy.
Mhm.
So, getting on proper hormones.
Mm,
When I wasn't on hormones to support what my body was doing, for hormonally with menopause, and I like the pre-menopause, I just didn't know. So, and I was not wanting to be on hormones. I was
mhm.
thinking that I
Yeah, of
was
course.
going to be superwoman or something like that. But it really helped. And it wasn't immediate. It took six
Mhm,
months to sort of level it out.
mhm,
Um, but the question I have is, I've heard a lot about cortisol, a lot. Does
mhm,
cortisol fit in the circadian rhythm? And because when people say, oh, you're having that exhaustion, and I would say, I'm going to change my wording, it's not exhaustion. I would say, now let me look at my notes. I'm probably in the category of brain fog about 1 to 2 o'clock-ish.
mhm.
Sometimes it's not every day. And so then people say, well, your cortisol, the reason why you're waking up is your cortisol. And then so how does that work?
Hmm. Um, So our cortisol is released in a way that kind of correlates with our circadian rhythm. We don't have consistent level of cortisol released throughout the day. It peaks in the morning, and then I think there might be a small peak in the afternoon, and then it tapers off towards bedtime. But anyone who's ever had their cortisol tested will know you have to go in first thing 8 a.m. for that early morning cortisol release or cortisol assay because they want to measure your cortisol when it's going to be the highest in your system. Um, I would say um, before cortisol is a hormone that I think is discussed a lot, kind of in the health and wellness space. And the way kind of allopathic medicine, so my training addresses low versus high cortisol, is a little bit different than I think it's conceptualized in other wellness spaces.
Okay.
Um, but from my perspective, low cortisol is a would be a medical emergency and is really defined by a like low blood pressure, extreme fatigue, and that's somebody who really needs medical assistance. That being said, that doesn't mean there aren't other types of like maybe what I would consider subclinical low cortisol.
Right.
But that's a little bit out of my scope, I would say.
Okay. Um, so um, so if we could move off of the cortisol, because I feel like circadian rhythm, cortisol, we've covered a lot of areas here. Now, what about so time change? Now, for me, the time the time changes, and I feel like I'm hit by a truck. And I'm looking at the time change that's starting in March, and now we fall back. I think we fall back. And so I live in Vancouver.
Mm.
So we're going, I believe it's back. But when we do that, it just throws off everything for me. And I'm sure other people as well. So how do we proactively look at things and say, okay, so when we have a disturbance in our environment that impacts winter, for example, the time changes, it's darker early. This is where people get it, like the whole body gets confused. How do we address this?
Yes, the time change is really challenging, and our the research out of sleep medicine shows that it's the time change that people tend to not like. The one that has more darkness hours is the one that's actually healthier for us and our circadian rhythms, um, which and the research is robust. They're seeing differences in heart attacks, differences in number of car accidents, and then they another piece of research is that when they compare SAT scores to school districts that have earlier start times versus late start times, there is like a 20 to 40 point difference or something in these test scores. So people just thrive better with consistency, and I really hear you with the suffering with the time change. I think there are regimens that you can partake in to kind of slowly adjust your body when we have an upcoming time change. You can adjust your sleep time by about 15 minutes for, the month prior to the time change if you wanted to try to do that.
Sure.
Um, a lot of times um that's a hard thing to commit to. And how I address it in my clinic is first of all saying validating absolutely our research shows that this is really hard on our bodies, and it's something that actually my medical society has been trying to get rid of for a long time. And then seeing what we can do in the kind of post time change period to support patients. Maybe we need to change the timing of sleep medicine and
Mhm.
just see what we can do to help.
Are there any foods that you can eat to help us with balancing our sleep?
I would say the biggest piece of nutritional advice I have is not eating big meals close to bedtime.
Okay.
Um, in terms of other kind of things that you can do to promote sleep, you know, being careful about like fluid consumption so you're not getting up and down throughout the
Yep.
night. Um, and I have found that a warm kind of glass of tea, an hour before bedtime can
Yeah.
really help. But otherwise, the robust evidence as far as nutrition goes is a little bit lacking.
What about magnesium?
Magnesium. So this is a big area of research right now. There are no, to my knowledge, no clinical guidelines regarding magnesium before bed.
Okay.
However, I have had patients who have been very significantly helped by magnesium glycinate supplements.
Okay.
And these are people who are having sleep fragmentations, and especially people with leg cramping. Um, that's been responsive.
Does the magnesium glycinate help snoring or apnea, or is that just that's an anatomical issue? This is the magnesium is for just overall system rebooting, kind of.
Yeah, I think that's a pretty good way to conceptualize it. And of course, talk to your physician before you start taking any supplement. But I would say the you're spot on with the snoring, the apnea being anatomical, and the magnesium glycinate maybe being more of something to try as a gentle first step if your sleep is really restless and disrupted. Um,
Hmm. Very interesting. Okay, so the sleep there I was looking up when I was doing some research, and there
yeah.
are so they talk about, so we've talked about there's six types of sleeping disorders, they say. Um maybe you can lack of sleep is one,
Okay.
snoring and sleep apnea,
Mm,
circadian rhythm disorders,
mm,
movement disorders, parasomnias.
mm.
So I would imagine that's like sleepwalking. What?
Yes. Yep.
I mean, there's nothing worse than that, I think. I remember as a parent being out cold, sleeping because, and a child is just standing there and they're talking to me, and you think you're in a horror movie. You're just like, oh, and they're not, they're looking through you, and you're just like,
I know. I know.
oh my God. But yeah, so do you treat that?
Yes, I do treat parasomnias. The one that I see most commonly in my clinic is sleep relating eating disorders. So
Oh,
people who, yeah, it's a interesting phenomena. When patients are getting up in the night, they're going to their refrigerator, they're opening it, they're eating a lot of times like raw or frozen food, and they don't remember the episode. Yeah, and I
oh.
the yeah, and if you they I think it's really difficult if they don't live with somebody or like you're saying, it's a terrifying experience to see somebody in that state, eating frozen meat or something. But it's very treatable, fortunately.
It's treat that is I've never heard of that.
Yeah. And a lot of times it's patients who, thank goodness, have connected with amazing sleep psychologists because they are having trouble losing weight. And they figure out that it's sleep relating eating disorder. They get referred to me. And a lot of times these conditions are amenable to a medication called topiramate or Topamax, just
Wow.
pretty low doses. And yeah,
Wow, that's very interesting. Well,
yeah,
I'm glad there's something for that, because that would be
yeah.
alarming if wake up and all of a sudden you're in your kitchen and you're eating something that's raw or frozen, and you're kind of thinking, what am I doing?
Yeah, exactly.
How do you talk to people if they feel embarrassed about any of these kinds of things? Like, what is because it's embarrassing. I think people say, oh, I'm snoring, or you're snoring, and then, no, I'm not. I'm not. There's an embarrassment or shame, or there's guilt in, you don't want to keep up your bed partner. You don't want them to stay awake. You want them to have a good sleep. And so when someone says, I didn't sleep because you were snoring, it's very hard. How would you help someone with some embarrassment, or doesn't know how to talk about it or accept the feedback?
Yes, I think this is so common. I get that. I'm embarrassed by my snoring. People with delayed circadian rhythm disorder or narcolepsy have been told for their whole lives that they're just lazy or are, that there's something wrong with them without the understanding that this is a disease that can be treated. Um, so I really like to start that conversation in any of those scenarios by just saying, it is it's bravery to admit
Mm.
this to somebody that you need help. And I think that speaks to your resiliency, your strength of character to come in and say, "Hey, can you help me with this because I'm interested in improving myself, improving my life, and I'm listening to my bed partner's concern and I'm here for help, and that's something we can do. The great thing about sleep medicine is it's happy medicine. All of our treatments really work. And that so it's usually, when somebody comes in like that, it's usually this sort of a very satisfying, gratifying, and productive journey. But really, I'm very supportive and congratulatory almost to
Yeah.
patients who are struggling like this because it is hard, it's embarrassing, but we've seen it before and we've seen worse, and there's always something we can try.
Hmm. I love that. We've seen it before, we've seen worse, and there's always something we can try. That really,
Yes.
because you do, people suffer. It's suffering,
Yes.
and at first it's funny, maybe, oh my, you take a video and of your bed partner snoring or something, and then but then it's not. It can be really sensitive because it's not, they're not doing it intentionally. And I think that's the
Exactly.
thing. It's
Yeah.
not intentional.
It's not intentional. It's not your fault, and you don't even know a lot of the time that this is occurring. And I think that that can be a strain too, because it's also on the bed partner to bring this to their partner's attention. So that can cause some tension. But again, like this, my wife says I'm snoring, or my wife is a nurse and she knows that you can fix this. Please help me. We see that a lot, and please come in because we can help you.
Yes, please go in because we can help.
Yeah.
That's another important key. So as we wrap up, I wrote down a few things. I wrote
Yes.
moms and dads. I wrote stress, menopause and andropause, and elderly. And what I'm looking for here is, obviously I've categorized people, and I'm not doing that intentionally, but I would like to have some advice for those women who are pregnant and they are struggling with sleep because they're brewing up a baby in there, and that's a difficult thing in and of itself. And then for the dads or the partners who are along there with them, also when you bring your baby home and there's that whole experience of feeding in the night and doing all the things, how do we take care of ourselves as two people who are looking, or one person who's looking after this newborn baby? What are the recommendations? What do you have for those people?
So the biggest piece of advice I can give is to take shifts. So instead, some people are tempted to kind of trade off throughout the
Yeah.
night. Oh, you do the first wakening, I'll do the second, but instead try to consolidate your sleep so that somebody's taking, or someone's awake from like 6 to p.m. to midnight, then somebody's doing midnight to 6 a.m. And that can consolidate sleep and give more hours to one partner over the other. It's not always possible, but when it that is the most solid piece of medical advice that I can give. I think understanding that sleep deprivation drives emotional fragility, emotional instability, and to just be gentle with yourself and your partner, because there's nothing that will make you feel worse on a day-to-day basis from my perspective than fractured sleep. And um just to really recognize that this may not be somebody coming to you with their most authentic self. This is a medical issue, and just to be kind and gentle.
Okay. That's very good. Being kind and gentle, because it can take an emotional toll.
Yes.
Absolutely.
Yes.
And then
Yes.
you have people who are the primary, they're out in the working field, they're working, and their job is stressing them, and they're coming home. How do they best prepare for a good night's sleep? How do you encourage, in terms of mental health or routine, that people learn how to leave the stress at the
Mhm.
door and then come home in a different way? How do you suggest for that?
I think this is can be incredibly difficult. We see this a lot in sleep clinic with people with very stressful or almost like scary jobs where they're, the EMS workers, the fighter fighters, the EMTs who have seen maybe a lot, and are stressed from what they had to deal with. And I think the best thing to do here is relaxation techniques like meditation, coming back into yourself, um, and deep breathing and recognizing that you and really setting up these rituals that will help you distinguish the outside environment from the home environment and promote kind of health and mental well-being in what should be a very sacred space.
Whoa. I absolutely love that. Coming back into yourself using meditation rituals that help you distinguish the outside versus the home, because the home could be a sacred place or should be a sacred place. Wow. I love that. Thank you.
Easier said than done.
I know, I know, I know. Okay, so now we hit the other stage where, ooh, maybe we talk about teenagers. How do you help teenagers with all of this as well?
Teenage sleep can be very difficult for a couple of reasons. Uh, one is a lot of and a lot of this is not within their control. For example, when we hit the teenage years, our sleep cycle naturally becomes delayed, so we crave later bedtimes with later awakening times, and a lot of times the school districts um, are not synchronizing high school start times with our body's natural circadian rhythm. So our teens are very sleep deprived during a time of growth and hormonal changes that just kind of make everything worse. Another big issue is phone time at night, the endless scrolls. These apps are really taking advantage of the teenage brain and making it very hard to put down, and log off.
Yeah.
So that's um, really trying to help them understand that this is something that they can do themselves instead of, forcefully taking things away. But unfortunately, that's a lot of what our counseling is
I
appropriate
forcefully take
use of
away.
electronics.
I
I
forcefully
know.
take away.
I hate
Every
doing it.
kid
No.
that has lived in
Yeah.
my home, I forcefully and with great joy take away. I
No,
love
I feel
taking
so
the phone
bad.
away. It's one of my favorite things to do. And you can ask any one of my kids. And so I can't take away my older three because they're old, they're adults.
Yeah.
Our youngest, she's 15, and she knows that that phone better be in my office at 9 o'clock. Period. There is nothing and nobody who needs to reach out to you
Yeah.
after 9 o'clock. And if you ask Dave, he would say that I'm being too kind. He would say 8:30. So so they go with me. But and and I don't hear that little patter of feet down the hall. That's there.
I love that.
No,
Yeah,
we need to start
that's the
taking
best thing to
our
do.
kids' phones away. Come on. Like what I want is, and this is what I've started doing. I used to have a phone box for when kids came over to the house and the phone went in the box. It didn't matter what kid it was and whose family they were from. Your phone goes in the box. And then of course, I don't know, but I think I got duped on that sometimes. I don't know. And then I don't know. I stopped caring. I stopped caring
Yeah.
because I just did. I was trying to manage other people's lives, and I'm like, look, if you just want to sit there and do nothing, then that's totally fine. Not even talk and just laugh at something else. But I think the bigger piece is that what you said, like learning to prep yourself a couple
Mhm.
hours before you go to bedtime and really like drain your lymph and connect to your body, journal, do something, right?
Yes.
Um, Waking up on your own is an interesting thing because I know someone who she lets her child wake up on their own and then takes her child to school. And I thought that was amazing. But if they have a math class at 9 a.m., you know, but her policy is no, we don't disturb this. And her child usually wakes up before 8, like around 7:30, 7:45. So how do we bring this into our life? How do you wake up on your own?
I think I think a big issue is in, this capitalist economy that rest and sleep is not prioritized, even though it's so important, that it can be really hard to make or get this message across that rest is just as important as the work part. But if we kind of make or encourage this paradigm shift where, oh, now it's actually important for me to rest as long as I'm listening to my body and resting as long and getting as much rest as my body is saying it needs, I think that's where kind of I would like to see things go, because a lot of the fatigue, the exhaustion, the sleep deprivation that's driving a lot of misery can be resolved with longer, or not even longer sleep, but an appropriate amount of sleep on a night to night basis.
Yeah, I think about young kids who are off to all of their exercises and their
Yeah.
activities, and they don't get home till 9:30, 10 o'clock at night or whatever it is, and then they're eating and then they're trying to unwind and they got to get up for school the next day. Uh, it's uh it's preparing them for something that is never going to end.
Yes, exactly. Exactly. And it's really, I have patients sometimes are like, oh, why can't I get up at 5 in the morning, so that I can be more productive? And well, I think the answer is maybe you don't need that product. What are you trying to get out of that extra 2 hours? I think it would be better for you if you were asleep.
It would be better for me if I was asleep. Yes, I'm just
Yes.
gonna that. Be better for me if I was asleep.
Yeah, I know. And it's like that will make you more productive actually in the long run. So
Will, absolutely, because then you probably won't have that dip in the afternoon, that sleepiness, that
exactly.
fatigue that we're talking about. Okay, so if
Right.
we're in menopause or andropause or premenopause, how can we, what do you have? What's the advice there?
This is tricky because a lot of the science as to why sleep worsens during this time, it's just not there.
Okay,
So we know that it happens, well documented clinical phenomenon, but not well understood. So my biggest advice is to, double down on your sleep hygiene, make sure, sleep schedule is consistent, 7 to 9 hours a night. Um, But if you're finding that that is not enough, then come see a sleep doctor because you might have developed sleep apnea, and we might need to up the insomnia treatment for you because you shouldn't suffer.
perfect. I agree with that. It's suffering enough knowing that you're, 45, 40, 50, and you're in this really weird change. It's
Mhm.
weird. And then if you're an elderly person, who, how do you recommend their sleep works for them, and any encouragement on that front?
I think as we get older, we need just as much sleep, but our circadian rhythm tends to advance. So that's kind of the joke about older people liking to eat early in the night. That's actually or earlier in the day, excuse me. That actually makes a lot of sense because they're going to bed naturally a little bit earlier, and to just for them to respect that bodily change. Is really, I think, all that you can ask of yourself. And again, if you're having symptoms that are bothering you, get it checked out because it's not always age, and there's a lot we can do to help.
Okay. So I think this is great. The last question I have for you as we wrap up is, I don't want to go to my doctor because my doctor doesn't listen to me.
Mm.
What do we do if that is what I mean, Dr. Lee, that's not what I think about you. You're my most favorite doctor. He knows it. He knows it. But if somebody has that thing where, like, I can't. I don't know, they just have a poor bedside manner or whatever. What if they just don't hear? Well, how do you help people whose doctor won't hear? How do we talk to them? How do we lead them in to this space?
I think really, for one, I think if you generally have a good relationship with your doctor and you find that they're just not hearing you on one thing, you can always ask, what signs would you tell me to look for if this gets worse? What signs would necessitate another opinion or a specialty opinion? And two, what would you want for your family member? And is that kind of the treatment that I'm getting? And is that like aligning right now with your thoughts on that?
Oh,
And then at the end of the day, if you can always ask for a second opinion. I really think this is a very important relationship in your life. And if you're not being heard, you deserve somebody who is going to hear you.
I agree. I absolutely agree. Um, Supplements?
Supplements, the biggest issue with supplements is that, from an American perspective, they're not FDA cleared. And
Sure.
there's a lot of people in this space who are take advantage of that and who are very good at marketing. And I would say if you're interested in a specific supplement, you can always ask your doctor about what that is.
Sure.
A lot of times, spending money on high quality, healthy food is going to be more productive.
Interesting. Oh my goodness, did I ever enjoy this conversation with
I
you?
know, I loved it. It was so much fun.
It's an hour and 15 minutes of conversation that is really, really important because you're a sleep doctor. And this is something that, you know, if I hear every day, it's always, oh, I'm tired. I didn't have a good enough sleep. What you've done here in this conflab is give us all of the ways in which we can learn, become curious, we can manage, we can develop a routine. I just love how you've done this. And I want to say thank you so much for reaching out to me and saying, hey, I have something to share here because you really did give us a full conversation. This is something to really think about. It's lots of education here. What would you like to say as we wrap up to those people who are out there listening? As a sleep doctor, what do you want to say?
I would say that you deserve to feel your best on a day-to-day basis. And if you have any questions about sleep, please come see us in the sleep medicine clinic because we're here to help.
I love. Well, thank you. Thank you so
Thank
much.
you. Oh, thank you so much for the opportunity. It was incredible.
Oh, well, I know there will be more questions and people will write in and ask, and I will always let you know if we have any questions so that you can answer those because you
Oh,
are the person who is qualified to do so. So thank you for joining with us today. I really appreciate it, and I wish you an incredible weekend and a good rest of your day.
oh, thank you so much. You too.